Can you hear me?
Yes.
Okay, good. Excellent. All right, slideshow from the beginning. Okay, there we go. All right, today we're going to talk about marijuana and the MOUD patient. The question that arises in my mind and probably in most of your minds is marijuana, does that mean relapse, or is that something that could be an adjunct to our treatment? And quite frankly, I didn't know. I had a patient that did not do well, and I wasn't sure I handled it right. So I'm going to present this case at the end of this. I chose this topic because I was hoping that I'd find the answer. And unfortunately, I have not. So with that, we'll start. What are the objectives today? Well, I want to make sure that everyone has a pretty decent understanding of what the many problems of the illicit marijuana that's available today for purchase on the streets, and to understand the complexities of cannabis and its mechanisms of action, and to discuss the unique problem of teen use of marijuana, because teenagers are, at least most of my patients, when they started using drugs, one of the first drugs they used besides alcohol was marijuana, and it was almost always as a teenager. We're going to discuss cannabis use disorder and cannabis withdrawal syndrome and try to understand a little bit about the relationship between cannabis and opiates, and then apply this to the case study. So, what is the cannabis plant? When we talk about cannabis, we're talking about three major species. The sativa, which is the type that is highest in THC, indica, and rudolaris. And what is happening today is cultivators are taking the three species and mixing them up in different combinations, and it results in many different phenotypes with a varying amount of THC and CBD. There are 537 chemical constituents, 107 of which are cannabinoids. We're going to just mainly focus on the two, the THC and CBD. THC, of course, is the psychoactive component with partial agonist activity at the CB1 and CB2 receptors. CBD is the component of marijuana that probably has the most potential for health benefits, the most potential for possible use in opiate use disorder. It has a very low affinity for the CB1 and CB2 receptors, limited abuse potential, and it does appear to inhibit drug-seeking behavior. So what are some of the problems today with marijuana? Well, number one, it's extremely popular. In 2015, a study was done which estimated that there was 22.2 million Americans, 12 years of age or older, who reported using marijuana within the previous 30 days. And that included 21% of high school seniors. It's pretty significant. Marijuana is very addictive, especially to state governors. They salivate over the billion plus in marijuana tax revenue. So politically, it's a big thing. Medically, it is now considered to be potentially addictive. It does have an identified withdrawal syndrome, so there are some problems there. One of the big problems with today's marijuana is it's very potent. I mean, back in the days when I was young and maybe smoking marijuana, I won't say, of course I was. Anyway, contained less than 2% THC. Marijuana today contains anywhere from 17 to 28% in the state of Colorado. CBD concentrations in marijuana are inversely related to the THC concentration. So the higher the THC concentration, the lower the CBD. It's increasingly contaminated with other substances such as fentanyl. So again, when someone buys marijuana off the street, they're not necessarily buying just marijuana, and that is a problem. And the recreational forms of marijuana products like oils, shatter, dabs, edibles, they can have concentrations that approach 95%. Now, the majority of them are in the 60 to 80% range, but that's still a substantial concentration. Marijuana is very historically misunderstood for most of the time since it was introduced in the 1800s in the United States. It was considered non-addictive and basically pretty harmless. However, there is a definite um, withdrawal symptoms that have been identified, and it is now considered an addictive substance. Marijuana, like all drugs of abuse, increase the release of dopamine from the nucleus accumbens, which is vital for long-term learning. People who smoke marijuana heavily, uh, they tend to have smaller hippocampus over time. The hippocampus is responsible for short-term memory and learning new things, and marijuana then can, by implication, impair performance on verbal learning. I said that we were going to discuss a little bit about adolescence. The problem that the majority of people who start smoking heavily in adolescence is of course, the time when the brain is completing its major development. And marijuana stimulates the dopaminergic and the glutaminergic neurotransmitters, and it decreases the serotonergic and GABAergic neurotransmitters in the prefrontal motor cortex, which is the seat of judgment. So what happens is you have less coordination, more impaired impulse control, poor judgment, and increased risk taking, which is a really bad combination that we see in teenage marijuana use. The other thing is that, according to a New Zealand study, looking at marijuana over time, when they were smoking at least 5 joints a week, they noted an average loss of 8 IQ points compared to non-smokers in the same age group. Now, 8 points for all you guys out there who are very, very bright and with extremely high IQs probably doesn't make any difference, but take somebody like me and lower 8 points, and I probably would have difficulty chewing gum and tying my shoes. Other problems with marijuana, one of the big problems is that there's no legal way to measure impairment. Blood alcohol, every state in the union has a cutoff of 0.08%. If you're 0.09%, you are intoxicated. It's a simple definition. It's easy to determine, and that's it. Whereas with marijuana, you can easily detect the metabolites, and you can find out if the patient has had exposure to marijuana, but it does not tell you whether the patient is acutely intoxicated or not. Cannabis can worsen anxiety, depression, psychosis, suicidal ideation, and frequent use of marijuana in a study of almost 35,000 patients showed that the risk of prescription opiate use was 4 times higher than non-users in a 3-year follow-up. So again, a significant problem. We're talking with street marijuana now. So what is the cannabis use disorder? Well, all substance abuse disorders have basically the same type of ingredients in their components in their definition, which includes continuous use despite adverse consequences, distress, significant impairment, and the inability to control the amount used, or sometimes to be able to stop. The DSM-5 for marijuana abuse or use disorder does require that the user have at least 1 year of using cannabis, and then have that accompanied by the severe impairment of functioning, which includes, and I have listed there, using more marijuana than intended, the inability to stop, having cravings. Use becomes more important than other vital areas of life, such as health, job, family, education, hygiene, etc. So the ICD-10 code F12.1 is for mild, and mild cannabis use disorder, and that would be 0 or two, actually, two different symptoms. Moderate is 2 to 5, and over 5 is severe, which is F12.20. So if we look at the cannabis use disorder, it is more common than people previously thought. In a 2016 study of lifetime users of marijuana, they found that approximately 20%, 1/5, met the criteria for cannabis use disorder. About a quarter of those, so in other words, 5% of lifetime users, were considered severe, and half of the severe people, which would then be about 2.5% of lifetime users, were considered non-functional in any major role. So they basically use marijuana all day. They just didn't care about doing anything else. Cannabis withdrawal syndrome is defined as the development of 3 or more of the following symptoms, and I have a pretty inclusive list there. Anger, anxiety, restlessness, depression, irritability, insomnia, tremors, loss of appetite, and cravings. Now, the syndrome usually starts right after cessation and is most intense for about a week after cessation. However, it can persist for as long as 30 days. The medical professionals have a lot of confusion amongst themselves about whether there's any benefit of marijuana in treating anxiety and depression. And it's sort of which came first, the chicken or the egg. If the anxiety and depression is the actual disorder that preceded or would have developed anyway, then one would think that marijuana use would perhaps improve their symptoms. That is definitely not been proven. On the other hand, if the anxiety and depression or mood disorder was resulted in the use of marijuana, and or if that developed before the anxiety depression, and part of the problem was cannabis use disorder and withdrawal, both of these things can display depression, anxiety, and all of this. And then, of course, if you're in withdrawal from cannabis and you use cannabis, your symptoms will go away. So therefore, your anxiety and depression responded to marijuana. We look at cannabis and opiates. We have to look at the opiatergic and the endocannabinoid systems to see how they work in the nervous system. The endocannabinoid system is what mediates the motivational effects of substances and substance-related cues. In other words, it makes drugs better. It makes them more pleasurable. CBD may play a role in MOUD, and we'll discuss a little bit more later, but it does seem to reduce some cravings and relapses in abstinent addicts. It impairs the drug reward memory system and inhibits the reward facilitating effects of opiates. The endocannabinoid system really consists of the CB1 and CB2 receptors. The CB1 receptors are mainly they can be anywhere, but they're commonly in the brain and periphery. CB2 receptors are mainly in the periphery, although they can be also seen in some areas in the brain also. The endocannabinoid system also consists of the ligands, which bind to the receptors, and to substances that increase or decrease the metabolism or catabolism of the ligands. Now, the endocannabinoid system acts synergistically with mu-opioid receptors. It potentiates the pleasurable effects of dopamine, of opiate, and dopamine is the primary neurotransmitter. there are many interactions between the endocannabinoid system and the opioidergic system. If we look at the CB1 receptor, this is, has a profound effect on the rewarding properties of opiates. The CB1 receptor and the mu-opioid receptors are distributed in many of the same areas of the brain. There are CB2 receptors in the ventral tegmental areas and in the, but not as much in the nucleus accumbens. Both of these areas are critical in moderating reward circuitry and opioid disinhibition, making, again, opiates more addictive. There is definite synergism between the endocannabinoid system and the opioidergic system. One of the things that people are saying is a possible advantage of marijuana is marijuana does reduce opiate usage. In Colorado and California, where recreational marijuana is legal, there is a definite decrease in opiate prescription use, and drug overdose rate is also less. So this could explain also the pain relief from marijuana. Disrupting the endocannabinoid system may be a way of treating opiate use disorder, particularly the reinforcement aspect of addiction, resulting in compulsive use, loss of control, and tolerance to pleasurable responses. Opiate in the ECS activation by marijuana may create long-lasting changes across the certain circuits in the brain from repeated exposure to high concentrations of dopamine from these, the use of marijuana or opiates, both of which obviously increase significantly the amount of dopamine secreted. And this can result in increased difficulty for the addict to stop because marijuana used by an opioid addict can increase the emotional learning and memory process that enhance the emotional response to opioids and make it much more pleasant to use opiates and much more difficult to quit. When we look at CBD, and I'm not going to spend very much time with that, it is non-psychoactive, minimal abuse potential. It doesn't stimulate the CB1 or CB2 receptors. In fact, it acts as a weak non-competitive antagonist of CB1 primary ligand binding sites. It does bind allosterically to the CB1 receptor near where the primary ligand site is, and it causes an alteration in the primary ligand binding site, making the site less responsive to normal binding, and so it impairs the CB1 function. It acts wherever there are CB1 and CB2 receptors. It's a pretty potent anti-inflammatory agent, has a very good safety profile. It does, as I said, inhibit drug-seeking behavior and the condition place preference, which is all part of this relapse behavior that occurs. It decreases stress and anxiety, especially anxiety from social phobias and generalized anxiety disorder. And it possibly reduces opiate withdrawal symptoms. So could it have a role in MOUD? Probably, possibly, I'm not sure. The results are not in yet. So to summarize, is there a role for cannabis and CBD in MOUD? I don't know. Could cannabis raise retention rates and make MOUD treatment programs more popular? Sure could. I mean, I can only imagine. You can smoke pot in this treatment program. I mean, I can only imagine. Could cannabis reduce opiate consumption and prevent opiate escalation? Again, possible. Or could cannabis be an example of opening Pandora's box and be a substitution for one substance over another? More research is needed, and the research needs to be on humans and not rats. Most of the studies that I read were on rats. It was very hard to be able to translate that to human studies. I don't have the answer, as the case presentation that I'm going to present illustrates. These are some of the references that I thought were the better ones, and does contain some of the information that I presented today. So let's talk about this case. CC oh, wait a minute. CC is a patient of mine, or was a patient of mine, who I initially started seeing in May 2017 for opiate use disorder. He gave me the following history. Started drinking at age 13, always to intoxication, drank with friends, usually on weekends, parties, etc. By age 15, he was introduced to marijuana and really liked it. He progressed very rapidly to daily smoking and was binge drinking alcohol on the weekends. In his early 20s, he was smoking marijuana daily and binge drinking about 3 to 4 times a week. So it wasn't just weekends anymore. He started experimenting with cocaine and other substances, but didn't like them and basically stuck with marijuana and alcohol. By early 30s, he had 2 DUIs. He couldn't hold a job. He was sentenced to AA. He did go, he was compliant, but he did nothing more than get his court papers signed. Age 35, however, he got drunk. He fell and injured himself, and this was his wake-up call. He, on his own, checked himself into a 5-day detox. He was referred to AA. He went this time, did 90 meetings in 90 days, but he never bothered to get a sponsor and he never did any step work. After a few months, he decided he didn't need AA anymore and that he wouldn't drink again. Well, he was half right. He didn't drink again, but as you'll see, he needed AA. He was completely abstinent until the early 40s when a friend of his introduced him to pain pills, and he loved them much better than marijuana or alcohol. His pain use, his pill use increased from chewing then to snorting. Within a year or so, he started smoking marijuana again as a reward for not drinking. And after a few years of using pills, he had to switch to heroin because it was cheaper and more available. He used heroin for a total of 13 years, never shot it, always snorted it. Used straight Suboxone intermittently when he had trouble obtaining or affording heroin. One day he simply woke up, made up his mind that he wasn't going to use anymore, and he called my office for an appointment. I recommended 3 to 4 AA meetings a week, recommended that he get a sponsor with daily sponsor contact if possible, and to work the steps. For the first 10 months, he did just that. He was going to 3 to 4 meetings a week. He got a sponsor he was talking to every day, and he worked through, I think, the 6th step. At that point, he decided he didn't need as many meetings. He dropped them down to 2 a week, and his sponsor and I basically gave him help. So he improved. He went back to 3 meetings a week. He started working on the steps harder, completed the steps. He got promotions at work. Life was doing very, very well until COVID. Unfortunately, this patient doesn't own a smartphone, doesn't own a computer, doesn't have internet, doesn't understand how to use a computer. So he did 1 phone meeting per week, which was unacceptable to both his sponsor and to myself. I asked him to work the steps the second time. He refused to do so. And since his sponsor was ragging on him every day, he decreased the contact with the sponsor down to 3 to 4 times a week. I saw him monthly and continued prescribing 12 milligrams of Suboxone per day. And from my standpoint, other than the fact that he wasn't doing the meetings, he still seemed to have it together, at least on Zoom. In May, when I first saw him in person, however, his urine was positive for THC. Both his sponsor and I were unhappy. His response to that was dropping the sponsor contact to once per week. He would not do his 1 phone meeting a week any longer. And I think he would have stopped seeing me if he was ready to stop taking Suboxone, but he wasn't. I talked to him, but I didn't threaten him, didn't do anything, to discourage him from continuing to come to see me monthly. I counseled him about marijuana. He simply stated that he was going to smoke. There was nothing wrong with it, and it helped him sleep and it helped him deal with anxiety. And he was not going to go back to meetings, and he was not going to go back to his sponsor. Eventually, he decided after about 3 months or so, he decided he was going to wean off Suboxone, and I discussed relapse prevention with him, which I automatically do with all patients who want to wean, and why I felt he needed to abstain from mood-altering substances. He refused to consider any of that. On my last visit, I decided to change things up a little. On his last visit, I decided to change things up a little bit. And I basically used the Ohio Medical Board as my excuse. And I said, look, in order for me to continue to prescribe for you, you have to have some form of counseling, and you're not getting anything at all. So please go to an addiction specialist or an addiction treatment program. See what they say. If they tell you that it's okay to use marijuana and it's okay not to have counseling, let them write me a little note, and that way I can continue to see you and continue to give you Suboxone. Well, that was not the right answer, and I've never seen him again. I did do a recent ORS check, and it indicated that he has not seen any other provider. So in the time we have left, and I see we have a good 20 minutes, I wrote some questions for discussion, questions that I would love for someone to help me with. I want to know, did my patient relapse? Did he relapse according to the abstention-only programs like 12-step or Smart Recovery? And I'd like to know how you would have handled this patient. Would you have discharged him? Would you have continued to prescribe and ignored the urine screens and lack of counseling? Would you have considered a higher level of care, as I eventually did? Or is there something I haven't thought about? And next, I would like to know how you feel about illicit marijuana. Is the use of street marijuana compatible with the goals of MOUD? And in my opinion, the goal of MOUD is to learn how to live life substance-free on life's terms. Another question I have is, if this patient resumed daily drinking instead of marijuana, would that have made a difference to how he should be handled? And if it would make a difference, why would you say this? And lastly, if this patient came to your office seeking Suboxone, but instead, twisting it up a little bit, he possessed a legal Ohio medical marijuana card, and you looked on ORS and saw that he was purchasing a sativa vape product, which contains 70.4% THC and 5.07% CBD, what would you do? I don't have answers to these questions. That's why I wrote them. So thank you. I'll end the sharing and open it up eagerly to your comments.